Healthcare and senior care is fraught with problems and challenges, but we're also seeing some amazing new clinical treatments and resources. This show will help illuminate and uncover the good, bad, and the ugly in order to equip patients, families, and other healthcare providers. Welcome to Senior Care Confidential. Hello, and welcome to another edition of Senior Care Confidential. I'm joined again with my co-host, nurse extraordinaire, Joe Alch.
Hello there. I'm glad to be here today.
Yeah, and today, because we see this so often, today we're going to be talking about falls. It is becoming one of the leading causes of death and loss of function for many seniors. And so there were some shocking statistics that we've uncovered. And I teach a class and several of the senior living communities around here. And the class is it's a 7-week class. And so it's structured in part of like, the first part is like educational part, and then the last part of it is more of a balanced kind of exercise piece. And so as we're going through these things, there's just a lot of really interesting information and I'm teaching these seniors that they just had no idea that when we think traditionally in falls, we think of, loss of balance or it's a strength issue. So, right, we usually will just send PT, get them stronger, get them more balanced, and they'll be fine. And in reality, there's so many things that go into this. And so that's kind of the point of our talk today.
Mm-hmm.
Yeah.
So there are just some statistics are kind of crazy. 1 of 5 falls causes a serious injury, such as a broken bone or head injury. Each year, 3 million older people are treated in the ER departments for fall injuries. 3 million people. Mm-hmm. Over 800,000 patients a year are hospitalized because of a fall injury, most often because of a head injury or hip fracture. Each year, at least 300,000 older adults are hospitalized for hip fractures. And as a registered nurse working in home care, that's what I see the most, is that dreaded, no one plans to fall. Yep. Nobody wants to fall and break a hip.
Yep, that's right.
So let's talk about that. Let's talk about falls are serious and they're costly.
Yes.
So how do you start your education?
Usually with a few jokes. Really what it is it comes down to, we are living in bodies that are older, notwithstanding biblical times. These are older bodies that we've been used to in like the last few centuries, right? And so if you look back at 200 years ago in the 1820s, do my math, the average life expectancy was like 38. Now there's some other things that go into that. There's nutritional aspects, and there's wars, I get all that kind of stuff. But the average life expectancy was 38. And then you get to 1920s and the average life expectancy was 54. And now we're roughly 80, plus or minus a couple of years. And so we are dealing with a lot more chronic issues now and older, more declined bodies, like functionally, than we had before. And so some of this is just kind of it's not really new, but within the last few decades, it's kind of a new world for us to be living in with bodies that are, that have declined to some degree. And so there's a lot of risk factors that go into these things. And one of the things that I'm a realist, and I don't think you can prevent 100% of falls, but my caution with anybody who thinks that falling is part of like the normal aging process, I cringe every time I hear that, because I know how the human brain works to some degree. And once you tell your brain falls are a normal, natural part of aging, then you shut off to any creative solutions to prevent future ones. So if we all agree that falls are going to happen, but there's plenty of ways that we know now to prevent them, and you're not going to prevent them in all cases, but there's a lot of factors that go into those. And so as part of this class that I teach, like every week is a structured thing, and there's different topics. And so one of the key things why I think a lot of people come to the class is because they do want to get stronger and they do want to work on balance and those kind of things. And so we do focus on those. And there's been some interesting studies. I think I've talked about this on the podcast before, but I'll bring it up just in case for new audience members. They did a study on 2 groups of 65-year-olds. And in one group, they led them through like a 5-month resistance training exercise class. And then the other group, they essentially put them in bed for 10 days. And what they found was the exercise group in 5 months gained roughly 2.5 pounds of muscle mass. Conversely, the other group that laid in bed for 10 days, they lost almost the equivalent amount. And so you lose it so much faster when we're older versus, when you're younger. In fact, there's some surgeries they'll do, like some cartilage replacements, things that they'll do like if you're in your 20s. But once you get into your 30s, because of how long you're non-weight bearing, they won't even attempt it because you just lose it so much faster. And so there is kind of still that use it or lose it principle with older bodies. And so I'm encouraged when I see a bunch of these seniors, because it's usually a few dozen that come in. I'm encouraged that they want to stay active, that they want to do those things. And so we guide them through some specific exercises. There's a program we teach them through. But that's only like a small piece of it. And I always tell them, like, listen, these first couple weeks when we're talking about the exercise, this is great. And these should be lifelong exercises that you maintain, because it's going to help you be more resilient and move around easier with less risk for falls. But there's also all these other things that we have to get into. And so one of those things is actually how the home environment is set up. And you and I know, because we've both been in home care, you private duty and now care management, and me in home health. There's a lot of homes that look nothing like the rehab hospital.
That's right.
Or the hospital.
Or they look like the hoarding show.
Yeah, yes, right.
Yes.
Or they were built in like the 1950s,
Right.
when I guess people were midgets and they were this this wide.
And they had 10 levels to the home.
Yes, exactly right. And so you have the multi-level living rooms and all these kind of things. And so all of those things, it's not like the one risk factor. It's not like, hey, I have a narrow doorway to get into the bathroom. That's the issue. It's the compounding effect of I have that, plus I have throw rugs, plus I've got a sunken living room, plus I've got a cat that runs around my feet, or any host of other things that we look at. Things like your favorite chair, if it moves, like if it's a rocker, recliner, swivel chair, and that's the chair you're having to get up and out, and you're in your 80s and it's getting tougher, like a non-stationary chair is hard to get in and out of. So there's a whole list of things that we go through to look at, even adaptive equipment in bathrooms and, in the toilet areas and around the shower. Like those things are really important because it gives you some security, because a lot of falls happen in the wet areas, bathrooms and showers. So we kind of go through some of the environmental hazards. And then I think one of the things that they're surprised at is on the medical condition side and the medications. So for example, did you know that there are 2 medications that show a 50% increase in fall risks, and they are antidepressants and anti-anxiety medications?
Wow.
Yeah, which, especially now post-COVID, I think we're seeing a lot more of those prescriptions given out.
I know there's psychiatrists that they cannot keep up with the demand. And
Yeah.
most of them, I've tried to find home psychiatrists or PAs that would go to clients' homes, and you can't find them. I mean, since COVID, they're all online, they're all Zoom, and they cannot keep up with the demand of people that need those types of medications.
Yeah. And I'm not here to criticize those medications at all. There's certainly a use case for those for sure. But the data seems to be indicating that there's a pretty high chance of falling if you're on those kind of medications. And it's probably because it's numbing the nervous the nervous system.
It's like having a glass of wine for the anti-anxiety.
Yeah. And the other thing we run into too is the insomniacs, the people who have a much more difficulty time falling asleep. And so they're groggy. So they take, the trazodones or whatever. And they wake up, for some of them, they're waking up in the middle of the night, having to go potty, and they're still kind of groggy from the medication and not sleeping very well. So we see a lot of like medicational type issues too. And we even get into, how to manage chronic illnesses in the class, because, depending on what you're dealing with, even congestive heart failure or diabetes, the loss of sensation with your feet, all these things can contribute to lack of awareness and lack of strength or endurance in moving around your home.
Well, you talk about these homes that are just weirdly set up.
Yeah.
So I have a patient right now that falls a lot. He is very depressed and has been on depression medication. And he has fallen a lot. So what we've done, he has a walker in every room. Because it's too hard to get from room A, even in the kitchen, to the living room, to the bedroom, to the bathroom. So we have a walker in each little station, and he'll stop with a walker in one room. You don't have to have one. You can have plenty of them.
We've done that in homes with narrow doorways.
Yes, but it has alleviated the falls. He has not been falling since we came up. We were just trying to figure out how do we do it. So that's one thing with home health. We're in the home and we see it. Yeah. So the doctors that are prescribing don't evaluate the home. They have no idea. Another thing too is with stairs, there are chairs that you can get that you can ride up the chair upstairs.
Yes.
So
it's like the old Gremlin movie.
Yeah, it is.
Deagle, deagle.
They're a little crazy. little pricey,
Yeah.
but it does work. So anyway, go on.
Yeah.
I was just thinking about my sweet
Yeah,
little
no,
guy.
we see a lot of those scenarios, and every home is a little bit different, and that's why it really is when you look at patient or senior safety risk factors, we categorize them in three main categories. We have one, the patient themselves, like what kind of medical diagnoses are they dealing with that may be contributing to any kind of a functional loss or whatever. Number two would be the actual home environment itself. Like what does it look like? What are the things that we're seeing, or narrow doorways, those kind of things, throw rugs, cords across the floor. We've got about 70 different things that we look at. And then number three is their interaction within the environment. So really with the cross section of those three things is really what we're looking at. So when we first assess a patient, we're having them walk through the entire home and do certain things so we can kind of get a picture in our mind of where are the risk factors for this particular individual. And every environment's different, every situation's different, the caregiver stuff is different, even so much as the equipment that they're using. So sometimes, we get these comments. In fact, I just got asked again yesterday about the stand-up walkers. Have you seen these, like the upright walkers?
I have a patient that I was just about to say the stand-up walker. They are fantastic. Yeah. He loves it.
So I just got asked another one. And I'll say I've never recommended it, and it's not that I don't. It's not that I don't like it.
This guy does great. I mean,
it depends on the individual client. So, so a lot of times, if you think they've done a really fantastic job marketing, I'm a little jealous because they've done a good job with that. Because everyone wants the upright walker. I want to be able to stand up nice and tall and look young and vibrant and those things. The challenge I run into with it is there's a medical condition that most of us will deal with as we get older called lumbar stenosis. And without getting into the weeds of that, a lot of people's doctors will say, it's kind of like, it's just arthritis of your back, which is not technically correct, but it gives somebody at least a baseline understanding of, okay, it's just wear and tear on my back, but it's a little more involved than that. And so essentially what happens is because of the way that the structures are designed in your back, even a slight bend forward can alleviate enough pressure on somebody's back where they can actually move around their home. And so for people who have lumbar stenosis, if I get them way up here, then I actually cause more of a deep ache in the back and they're less functional. And so we have had a couple patients with the upright walkers. They swear by them. I just, smile and go, okay, I'm glad it works for you. But choosing the right device. And sometimes that's hard because you'll have some people, especially in the senior living environments, everyone wants to drive the Corvette. And so they all want the flashy, four-wheel walker, the pretty one with the brakes and the seat and all that kind of stuff. Right. And they don't want to use the foldable one because it looks more medical.
One, right. Yeah. The silver.
And so the challenge with those is if you're someone who's a higher fall risk, more often than not, this is not always the case, but more often than not, you're better off with the foldable one because it's inherently more stable. Those four-wheel walkers, they got the caster wheels in the front and those kind of things. But everyone opts for that because for a couple of reasons. One, it looks flashier and it looks like you're not as handicapped.
Old.
That's right.
That's what they tell me.
And it's utilitarian, right? Because it's got the basket. Because what ends up happening is if you get somebody like a normal standard walker and they're having to walk around their home and they want to go to the kitchen to get a cup of coffee or a plate of cookies, they have a couple options with the standard walker, like the two wheels in the front, like skis. By the way, we recommend skis in the back. They can either leave the walker and walk in the kitchen and go get it because the walker requires two hands, or they can counter surf. They leave the walker and counter surf with it, or they'll take the walker in and they'll hold the walker with one hand and then hold the plate with the other hand and then rest the arm on the walker and push it that way. Mm-hmm. And so a lot of times if you can just solve the utilitarian part and just get them a basket or a tray, that kind of solves that piece of it. But even the devices that we see, I can't tell you how many times we see the wrong wheelchair, the wrong walker, the wrong setup, or the brakes don't work on the walkers or wheelchairs.
And let's talk about canes. Because canes, I was trained even in nursing school, canes are a false sense of security. So what are your thoughts on canes?
I like them for the right client, for the right patient. If you are someone who just needs a little added security, then it's fine. If you're someone who is generally mobile and may have some mild discomfort like in a hip or a knee, and you just need something to just give you a little extra, then I think it's fine. If you're someone who has a history of falls, they're probably the wrong device. And the other thing with that is, there's two types of canes. You've got the single point canes, and then you've got those, the quad canes. They look like a tabletop, right? Do you know why a lot of people choose the tabletop looking one? So if you poll, and I ask this in every class I teach, I said, why do you think people choose the 4-prong cane over the single point one? And invariably they all get it right. They'll say, because it stands up.
Yeah, it seems like it would be safer.
No, it just stands up. They just don't want to.
That's funny.
They don't want to have to find a place to hang it or lay it on the ground. So it stands up. So now there's kind of a hybrid model where it's almost like a foot. Like some of them have like 3 things on there, but it's small. It's a small footprint, and it's got like a real heavy hinge on it. So it actually mimics like a standard cane. The problem with the 4-prong walkers, we call it the quad canes, is that it forces you to walk differently. So in order for that thing to function the way it's supposed to be, you have to have all 4 feet, if you will, on the floor at the same time. And so it's almost like a wedding march. So cane, step, step, cane, step, step, and no one wants to walk that slow. And so a lot of people you'll see with those quad canes, they'll be walking like they would walk with a normal one, and that thing's just doing this. Like they've lost the benefit of having something with more stability. They've lost because of how they're walking with it. So it's really rare that I recommend the quad cane, just because it's either, in my world, it's either the cane or it's a walker. And going back to some of the walkers, like sometimes, even though they're a higher fall risk with the 4-wheel walker, like we were talking before, because it's got the caster wheels, so it's a little more squirrely for some people. So from a stability standpoint, the foldable walker, the one you see in the hospitals, those might be better options for them. But with certain people, like I have people who have Parkinson's, and there's a difficulty in just getting their walking pattern started. Mm-hmm. And so if there's something where if we lean them slightly forward and get the walker actually moving, it triggers something in the brain where the feet start moving. And so for them, a walker that doesn't kind of move easily actually becomes an impediment to walking. So it's not always a hard and fast rule of, hey, if this is a stability issue, use this, or if it's an endurance issue and I need a chair, use this. Sometimes, depending on what the needs of the patient are, we're modifying those things as well.
Okay, so I have another question. So I get this a lot too. A lot of my clients really need a hospital bed, but they don't want a hospital bed. They want to be in their own bed, and they want a rail.
Yep.
They want and you can get them at Amazon. Mm-hmm. They're those portable rails. Yep. I have not found that they work.
What are you finding?
I find that they're not safe. I find
that they're not stable.
They're not stable.
They're too easily moved.
They're too easily moved.
Okay.
They don't stay where they're supposed to stay, and my patients fall down. So I think with the hospital bed, there's just a better sense of security.
Okay.
What are your thoughts?
I think it depends on the bed cane that they use. So we'll do 2 different definitions. There's a bed cane, which is a smaller device about yay. Sometimes it comes up as like a pole, and then it kind of shoots out like this. And other times they're a little bit longer or wider, more of a rectangular position or shape. In those cases, that we're going to call that a bed cane, and then you have the bed rail, which is going to go.
And I've never heard of a bed cane. Yeah. I'm a nurse, and I've never heard of a bed cane.
Well, that's why I say we're going to define it for our purposes here. In fact, if you look on Amazon, some of them will actually be called bed canes because they kind of mimic a cane, but they're narrower in size. Versus like a bed rail, you usually think of a bed rail as something that's going to keep somebody in the bed. And in some facilities, like senior living communities, they won't allow them because it's seen as a restraint. So when we talk about recommendations for a bed rail, we're talking about a bed cane because we're using it for some sort of a functional reason, getting in and out of bed.
Would they qualify as okay in a assisted living?
Yeah, absolutely. We use them all the time. Yeah.
And
so because it's blocking, it's not even blocking their access to the bed. It's only this wide. Okay, so it's just there as a handle, right? No more than like an armrest on a couch would be considered a restraint. Right. It's just there for something to pull up on. So it depends on the style that you get. The ones that I like to use, and it depends on when you have adjustable beds, it changes a little bit. But if it's just a flat bed, the ones I like look like a T. So this piece here goes underneath the mattress, between the mattress and the box spring. And then this piece here sits on the floor. And then you have the handle kind of here.
Well, that's great.
Yeah, so it looks like a T.
Great to know.
The other ones that are, and by the way, this piece here, you wrap around. There's usually a nylon strap that wraps around the box spring. So it keeps it from moving. Because part of it is if, like I have a really heavy mattress, I'm a big guy, so I have a big mattress and it's heavy. But for some people, like their mattress is like this thin. And the second they go to pull up on that thing's trying to pick up the mattress behind them. So you want ones that are going to strap down. So I always recommend those. Another option for people who have, in some cases, the one I just described actually works well for the adjustable beds, but in some cases it doesn't because of how the furniture layout is. And so there's another version that doesn't have, remember the T, it doesn't have this bottom portion. It's just like an L. So there's nothing that touches the floor, which makes it a little bit less stable, right? Because if there's nothing on the floor, it's going to move a little more with the mattress. But this piece is usually a little bit longer into the mattress, and so you can strap that one down too, and those work pretty well. So I like those, and I just had this conversation with somebody else about this yesterday. What do they recommend on those? And that's what we decided.
Wow, that's interesting. Yeah. Yes. Yeah, because I do get worried. When a bed is flat, just trying to get out of bed if you're a little overweight or just lung issues or
and
cardiac.
to your point, we see a lot of we hear a lot about falls at nighttime and falls out of bed. And some of them are legit, like they just don't have the strength to get out of bed. Or some of it is actually that the bed's the wrong style. So one of the ones that we want to be careful of is anything that's too high. So I love the little old ladies who have their princess beds that they have to climb up on the stairs with because they're adorable when they do that. The problem is they don't fit on those.
Right.
And at some point, these
They're
become
so pretty, though.
I know they are. They're nice 4-poster beds. And they've got, oh no, I got a little stool that I step on. I'm like, oh my God. So those we actually want to drop down if we can. And so you want to get them to where when their bottom is sitting on the edge of the mattress, their feet can be flat on the floor. And one of the challenges is most of the beds are too high, especially for females. For guys, we're just built bigger. But especially for females, the thing we run into is the beds are too high. Mm-hmm. And so when they get their feet out of the bed, that side of the mattress becomes like a slide. Combine that with I'll avoid using name brands, but a foam mattress that does not have a reinforced sidewall. Like innerspring mattresses have a sidewall around them, and so it prevents that side from collapsing so much. With the foam beds or latex beds, you don't have that. It just collapses. And so now you have really a built-in slide. And so sometimes the fix is to do what we said, like lower the bed. Sometimes it's lowering the bed in addition to adding a rail. And sometimes for some people, because they're just, when you're trying to get your brain to figure out how to stand up, what your brain's thinking is push the knees so that I stand up tall, right? But when your brain is also concerned that you are a fall risk, it naturally wants to kind of push you back in the bed. And so sometimes your feet don't actually push you up. Your feet actually push forward on the floor.
Wow.
And so you'll see people slip and fall that way too, trying to get out of bed. And so in some cases, we'll actually put some non-skid tape there, or we'll put like a very low profile, like rubber backed mat there. So they have a little bit of traction. So the bed stuff, there's a lot of variables that go into bed safety. Those are just kind of a few of them. And if you solve all those other issues, let's say the bed's amazing, it's the right height, it's the right width, it's the right, density on the side, and we've got the perfect bed cane, and they're still having falls. Sometimes it's just there's an impulsive nature to that particular patient or client, and maybe something like a bed alarm. For some people with cognitive decline, that irritating alarm is enough for them to roll back over and get back on the pad. For others, it's just to alert a caregiver so they can come see them. But there's so many different scenarios, even with something as simple as a bed.
Mm-hmm. Yeah, I like those alarms. I think those are good for when you're concerned about falling.
Yeah, they make them for chairs too, and so we will utilize those. Usually, here's another thing too. As therapists, we're usually taught to maximize somebody's independence, and what I would say is our job is to maximize somebody's safe independence. And there are times where we will be asked by family members to work with an individual client who doesn't, over time we'll figure this out, but doesn't display enough impulse control to where if we actually get them stronger, they actually become a higher fall risk. And this is sometimes a challenging conversation to have with family members. It's like, listen, there's trade-offs in this world, and we can make them stronger, and we can get them where they move around with you easier, and all that's wonderful. And if that's what you want, we can certainly work on that. But be aware that his or her mental state right now doesn't understand that every time they try to stand up, they're at a fall risk. And so they're not going to be calling you for help. and that becomes an issue. And so we have to kind of have those conversations with them too. So we got to be careful on making them too strong and too mobile, because if we can't match the balance to that, then we've actually increased their risk for falls.
My grandmother would fall. She was black and blue when we moved her out of her home. And she wouldn't tell us, though, because she knew if she told us, we'd be like, "Grandmother, what are you doing?" And she was fiercely independent. And I know it hurt her. She never broke anything, but she looked terrible.
Well, you think the last thing they ever want to admit to is that, right? Because that is a very visible sign that I'm declining, and no one wants to feel it. It's like masking dementia. Nobody wants to have to admit that I'm seeing some changes now. So we see that a lot. And so we actually define, when we talk to new patients, we tell them this all the time, like, okay, how many falls have you had, like, in the last 2 months or the last year? And I say, before you answer that, our definition of a fall is any unwanted change in elevation. Like, in other words, if the wall hadn't been there, you'd have been on the floor. If the chair hadn't been there when you pushed up, you'd have been on the floor. If your spouse hadn't been there when you lost your balance, you'd have been on the floor. And all of a sudden that number is way, way higher. And that's really the true, because all we're trying to do is we're not trying to beat them down and try to, oh my gosh, like, we're just trying to figure out what's the true risk here in terms of what your balance really looks like. And so that gives us an indication of what kind of things we need to be working on, because if there's a large number of those, we have some other issues we probably need to be addressing. And some of those, honestly, I'll tell you, one of the number one things I see is with dizziness. So, and I when I do this class, I educate the seniors, and I try to avoid, I can go into the details too much, but I try to avoid getting too much in details. But there's really two classifications of dizziness. There's the common, like, I feel lightheaded type thing, like, you haven't eaten or your blood pressure is too low or whatever. That's one side of dizziness. The other side is more like a vertigo, and that's like defined like if you've been on a merry-go-round and you step off, your eyes are still kind of spinning. It's because your inner ear is still being convinced that you're moving. And those, when there are sometimes we get orders from doctors to treat vertigo, and it's not vertigo. And so, it's really important to make sure you get with a therapist. It's okay if we get the orders, we'll figure out what's going on with it. But it's important to get with a therapist who can differentially diagnose between those two things, because the treatment strategy for those is very, very different. And so one of the more common ones that we see very regularly in our world is what we call orthostatic hypotension. And it's just a fancy word, this, but for the audience, it's a word that describes, as we get older, our body's ability to it's not really self-monitor, but self-regulate the blood pressure becomes slower. So the reaction time is slower. So when you go from lying down to sitting or sitting to standing, there's a sudden drop in blood pressure. And some people are more affected by that than others. And when we have some of these people who are already starting off with low blood pressures, and then they drop another 20 or 30 points,
it's scary.
That's causing falls. And we see this all the time. In fact, I check for this on almost every one of my patients because we've been seeing it so often. Some of it is it's a hydration issue, which we don't even get into. Like in my class, I do a little bit, but I'll tell you that you know this as a nurse, but for the audience, like, one of the number one things we see people in hospitals for, and in addition to falls, is UTIs and dehydration.
I know, all the time.
And it's crazy. And so when you start to educate seniors on it, you're like, okay, so what happens with our bladder as we get older? Of course, everyone's getting up to go to the bathroom a few times a night, so they stop drinking water. Well, what happens when you stop drinking water? Well, then you get dehydrated. What happens when you dehydrate? Well, you're not flushing your urinary tract anymore, and so you develop these infections. Also, if you're not remaining hydrated, your blood pressure drops. So there's all these things just by not staying hydrated. So we put a lot of our patients on hydration schedules.
That's great.
Because it's becoming a big culprit in falls. So that's why I say, like, we started this conversation about safety risk and falls, and a lot of times the treatment strategy for falls is get them stronger and get them more balanced. Well, there's all these other things that go into that we need to be looking for as well.
But Brian, many home healths do not do the detailed care plan that you do at Nexus. And so share with the audience, how do we get in touch with Nexus Home Health?
Thank you. So you can just email me at Brian@Nexus, nexushomehealthcare.com. But yeah, so we actually, I own the intellectual property for it. We developed some clinical models and some scoring tools that allow us to we'll use the word risk stratify. Essentially all it is we know what benchmarks are. We look at those scores that we have on an individual patient. We can tell which ones are at higher risk for falls, for hospitalizations, and those kind of things. And then we build our care plans around those specific risk profiles, and that's what we end up doing. So, since you asked, I'll share. So we have this data analytics company that we pay for, and they look at a lot of Medicare expenditures. And one of the ones that we've never had access to before was one that determines how effective we are long term, which is a big thing for us, right? So, we've talked at length before about wanting to be proactive and preventive. That's why we do classes like this, or a podcast like this. That's why we teach classes, is because we want people to be educated so they can help become better for themselves, for their own healthcare.
Absolutely.
So we can avoid costs and those kind of things, and heartbreak and all that. And so, but before now, I've not really had the ability to see like what our effect is on the costs for people. And so we pay for this company now that looks at the 12-month spend. And so and it's 12 months after discharge from home health. So if you're looking at how do you define in a numerical way, how do you define how effective you are at putting in longer term systems that are effective for patients, it would be that number, right? So the fewer dollars spent means fewer hospitalizations, fewer surgeries, those kind of things. And so for Nexus Home Healthcare, we are roughly 33 to 34% lower than for the industry average for DFW and the state of Texas.
That is amazing.
And it's because we do look at, it's just, I used to work in research, and so we just look at a lot of things with a little bit more specificity than we were trained to do in schools. And so it translates really, really well to the senior care population.
Well, I know this fall you're going to do some teaching at a big church in Dallas.
Yes.
But if there's a community that wants to have your classes, how can they reach out to you?
Same thing.
That?
So I teach this in several of the independent living communities. I will say this, for assisted living, it's a little bit different because the class it's really geared towards more of an independent living. They can have some assisted device. They can still be using a walker. They can still be using a cane. But the level of function that you need for some of the exercises is a little more advanced than assisted livings would probably for the average assisted living resident. So for independent livings, for sure, we do them in several of them that last about 7 weeks. I should say.
That's awesome.
Yeah. So it's about an hour-long class. We do it for 7 weeks. It's a widely attended class. And
is there a cost?
No cost. I don't charge anything for it.
That's great.
We started doing it. Honestly, we did it because I was working in a bunch of these independent living communities, and there's, unlike assisted living, there's no nurse there. There's no wellness director, none of that kind of stuff. And I'm like, we see all these falls, we see all these other issues. Let's start doing something to help educate the seniors that are here. And so that's why we started offering this class. And it's just become, it's become a great thing for me because it's, it gets our name out there more, but it's also been wonderful for the family members too, because now they've got someone to come to if they have any issues. And the seniors, I have repeat attendees, and every time, when the 7th class and the graduation class comes around, every time, like, when are you going to do this again?
Oh,
so
that's awesome.
It's a fun class to teach.
People love education.
Yeah.
The older we get, we just, they just want to stay healthy.
That's right.
And stay independent.
And we cut up and we make jokes, and it's a really fun class though. I really enjoy teaching it.
That's great.
Yeah. So thank you for asking.
This has been great.
Yeah.
I've loved learning about preventing falls, and nobody wants to fall.
No.
And we want to stay safe. We want you to stay safe. So if you need a wonderful home health, I highly recommend Nexus. They do a great job. Easy to talk to. I've called and you all have been out within 24 hours, and that's been fantastic.
Thank you for that.
Thank you for that. What is your phone number, Brian?
My personal cell phone number is 321-271-4052. And our office number is 469-317-3017. But you can call or you can text or email. If there's a senior living community out there that wants us to teach these classes in them, if there's a family that's concerned about a fall for a loved one, we're happy to consult with you on that one and kind of see what specifics in that environment we need to be addressing.
What counties are you in?
Dallas, Denton, and Collin, and
great.
Rockwall.
Great.
Yeah.
Thank you, Brian.
Thank you, Joe.
It was
Appreciate
great. It's been a great show, and just stay healthy and
we'll see you next time.
don't fall.
Yeah.